Good morning and good afternoon and good evening, depending on what part of the world you're in. It's a pleasure for me to be involved with the Spine20 virtual meeting. And today's session is really very timely, and we're dealing with the management of the aging population. And I'll be reviewing the changing epidemiology of spine disorders related to aging. I have no commercial disclosures, but I wish to acknowledge my resident Ali Mogadamju for the assistance putting this talk together, and also for the gracious invitation by Dr. Sami Abraham Alisa. Aging is a natural, inevitable physiological change that leads to compromises in physical, mental, and functional abilities, and this represents a decreased capacity for regeneration and repair. And there are many implications for medical practice and specifically for spine. The epidemiology of our world population is changing, and this is reflected by these statistics, which we reported on related to acute spinal cord injury and traumatic brain injury. We recognize that the overall incidence of spinal cord injury is stable, but patients are getting older, there are more fall mechanisms, and there are more cervical injuries. It is clear that we're experiencing a shift in the population age structure related to increased longevity. And we're also experiencing an epidemiological transition from infectious diseases to diseases of chronicity, aging, and degeneration. And there are important implications for the spine, as illustrated in this montage of photographs, where I've shown examples of degenerative cervical myelopathy, degenerative scoliosis and deformity, fragility fractures, including type 2 odontoid fractures, lumbar spinal stenosis, osteoporosis, spondylolisthesis, kyphosis, and so on. So aging leads to biochemical and biomechanical alterations of the spine, and this can progress to micro and macrostructural changes. This has implications for the intervertebral discs, where there's a loss of aggregate and water with aging. The facet joints undergo degeneration, and as a result of altered load-bearing functions, this can result in degenerative spondylolisthesis and scoliosis. The vertebral bodies undergo age-related remodeling, and there are changes in bone mass and mineral density, leading to osteoporosis. And the soft tissues also change related to aging. There are alterations in elastin and collagen. With aging, the ligamentum flavum may thicken and buckle. In addition, there are degenerative changes to the muscles. And there are neurological changes which occur within the spinal cord. So there's a decreased density of small myelinated fibers in the corticospinal tract, and aging is associated with a reduced number of small neurons in the intermediate zone of the ventral horn. And there are a variety of spinal disorders in the elderly, which range from a host of degenerative conditions. This can lead to deformity. There are certain traumatic conditions, including compression fractures, central cord syndrome, type 2 odontoid fractures, which are quite typical in the elderly. The elderly are more prone to metastatic disease, as well as infections and certain inflammatory conditions. Individuals over the age of 80 have a 3 times greater chance to experience low back pain and lumbar degenerative disorders. The decision to treat surgically or non-operatively should be made individually in this case, and one should not simply write off individuals because they have a certain age. One really needs to use a personalized medicine approach. And the trick is to avoid too much surgery, but also too little surgery, and to tailor the surgical approach, which is ideal for the patient. I'll just go through a number of conditions which are specific to the elderly, and then I'll conclude with some overall recommendations in terms of next steps. So degenerative cervical diseases, in particular degenerative cervical myelopathy, is a common cause of disability and global disease burden. And we recognize that elderly patients do improve with surgery, although their functional benefits are somewhat less, and this needs to be taken into consideration. Nonetheless, advanced age should not be a contraindication to the surgical treatment of degenerative cervical myelopathy. Elderly patients are more susceptible to injury, particularly related to falls. In spinal cord injury, hospital admissions of geriatric patients have increased fivefold in the last 25 years. And in westernized society, spinal cord injury is shifting toward a disease of the elderly. This has important implications if we look at these survival curves from work that we published in the past year, and we see in the blue a younger age cohort, and in the orange an older age a cohort of patients over age 65, and quite dramatic differences in survival. Because of increased frailty and reduced physiological reserves, the elderly are more prone to secondary complications. Nonetheless, the treatment goals remain unchanged, and these should be directed toward pain relief, early mobilization, preservation of spinal balance, and prevention of late neurologic complications. When we consider fragility fractures, including type 2 odontoid fractures, this represents particular challenges in the elderly. Nonetheless, the data do indicate that surgical intervention in these patients appears to be of benefit. Traumatic central cord syndrome is rapidly becoming the most common form of spinal cord injury that we're seeing, and the emerging evidence indicates that early surgical decompression is safe and effective in terms of improving neurological and functional outcomes. The elderly are more prone to spinal tumors, in particular metastatic lesions, as well as hematologic disorders, including lymphoma and myeloma. How can we minimize the poor outcomes associated with the elderly and enhance the positive impact? An important concept here is to consider the issue of frailty. So age is not a modifiable risk factor, but certain aspects which contribute to frailty may be. So let's think about some practical next steps. I'll go over each of these briefly. One is to optimize the patient's status preoperatively. And here a structured multidisciplinary team is of value, and one may consider a so-called prehabilitation approach. That is to use rehabilitation prior to surgical intervention. Elderly patients are less likely to undergo surgery within 24 hours post-injury in the setting of spinal cord injury. And this is somewhat at variance with the emerging data indicating that earlier treatment is beneficial. So it is important to maintain timely access to specialized care and to ensure that the elderly also have access to this. Prevention is critical when managing spinal disorders in the elderly. Falls are often the cause of spinal injury, as is osteoporosis, and prevention strategies directed toward these two issues can have an important impact. It's important to consider the postoperative care, and a multidisciplinary team is essential to avoid complications such as a delirium. It's important to institute programs of early mobilization and a structured rehabilitation program. Enhanced education among healthcare professionals related to disorders of aging in the spinal population is particularly important. And finally, we need more research. We still do not fully understand the natural history of spinal disorders in the elderly, and we need to examine strategies to enhance outcomes. And on that note, I'd like to conclude and thank you very much for the opportunity to participate in Spine20.